Hello, everyone. Thank you for joining us and welcome to our COVID-19 and Canadian Net Patient Care webinar with Dr. Julie Hallet. Just to let you know that the format of today's webinar is going to be strictly question and answer, so we're not going to have any formal presentation. We'll take questions from participants via the chat function on this webinar forum, and you'll find the chat function on the right-hand side of your screen if you can just write in any questions that you may have, and we'll try to get to all of them. We're going to ask that the questions or your questions be focused on COVID-19 and warn that Dr. Hallet may not be in a position to respond to questions that are specific to your personal health situation or your care. So it's my pleasure to introduce you to Dr. Hallet, who is a surgical oncologist at Sunnybrook Health Sciences in Toronto, Ontario. She's an assistant professor of surgery at the University of Toronto as well. Dr. Hallet is one of 4 core oncologists at the Susan Leslie Multidisciplinary Neuroendocrine Tumors Clinic. As a surgeon investigator, her research focuses on health services population-based research to examine cancer processes of care and outcomes. She leads a research program dedicated to assessing and understanding the integration of patient-reported outcomes and standardized therapy for neuroendocrine tumors, supported by operating grants from the CIHR and the NANETS Clinical Investigator Scholarship. Dr. Hallet, thank you so much for taking the time out of what must be an incredibly busy schedule for you. We appreciate your support of the NET patient community.
Oh, thank you so much for the invite, Jackie. I'm really privileged to be here and be able to answer some of the questions as best as I can.
Wonderful.
I just want to preface this by just mentioning that of course, COVID-19 is something that's evolving very, very quickly, and we're gathering more knowledge and information about the virus, about the pandemic and its effects on all types of patients, the general population every day. So I'm going to answer the best of my knowledge and the best of the knowledge we have right now as a scientific community, but things might change over time, even following this webinar.
Very much, we appreciate that. So we did take some questions in advance that we received via our online Facebook support forum. So we're going to kick off the event with some of those questions. So just to start off, can you please tell us if neuroendocrine patients in general are more susceptible to COVID-19 than the general population?
That's a very good question, a great opener. So actually, we do not know that neuroendocrine patients specifically as a group are more susceptible to COVID-19. So to either getting COVID-19 or getting worse outcomes if they have COVID-19. There is actually very little information about cancer in general, even less so about neuroendocrine tumors in particular. So what we know is there are a few cancer patients out of China that had COVID-19. And some from that have said that cancer patients are at higher risk of getting COVID-19. What you have to know is that is based on 18 patients with cancer total into a study of over 1,500 patients. So it's really uncertain exactly what is going on there. At the end of the day, the susceptibility to get a COVID-19 infection and the outcomes of COVID-19 are probably dependent on either the type of neuroendocrine tumors and the type of treatment and at what stage of treatment are patients related. So one thing that comes to mind is in terms of the type of neuroendocrine tumor is patients with long neuroendocrine tumors that might have already long disease or long compromise from their tumors might be at higher risk of having a hard time if they get COVID-19. Not necessarily a high risk of getting the infection, but if they have it and have pneumonia from the infection, might be more difficult to fight if there's already a long compromise from the tumor. So that's a very small group of patients. And then the second thing is depending on the therapy you're getting, there might be more susceptibility to infections or to managing with the infection. Things that come to mind are, for example, people that are on everolimus or Afinitor. One of the side effects of that drug is pneumonitis, so an irritation of the lungs. So if you have that side effect of the medication and you get COVID-19 and you get a pneumonia from COVID-19, so multiple things have to align, that might be more difficult to fight the pneumonia. And then the last thing in terms of therapy is there are a few patients with neuroendocrine tumor that might be on intravenous chemotherapy that might reduce the ability of the immune system to fight the infection. But that again is not all patients on chemotherapy, and it's not during the entire treatment of chemotherapy. There are certain moments where that is true throughout the treatment, and overall patients are not at higher risk. So in general, I would say there's no higher risk of getting COVID-19 or doing worse from COVID-19, except in very specific circumstances, which would be a minority of neuroendocrine patients.
Okay, that's great. Thank you. So what about patients who've had surgery and they don't have a spleen and they're perhaps diabetic as well? Would they have any higher risk?
So that's an interesting question. It comes back quite often if you look at the different neuroendocrine tumor webinars that have happened recently. So there's two things here. The first one is with regard to the spleen. So anyone who had a splenectomy might have heard there's a high risk of infection. Now, what you have to know is infections you can get if the spleen is gone is a very specific type of infection to what we call encapsulated bacteria. So it's 3 specific type of bacteria, including Haemophilus influenzae and the meningococcal bacteria. And it's really for bacteria. It's not for virus. So the spleen doesn't have a role to play in fighting virus infection. All that to say that if the spleen is gone, you are not at higher risk of COVID-19 and you don't have a harder time fighting COVID-19. So that's for the spleen piece. With regards to surgery, the answer is we're not sure, but there's no reason to think that patients who had surgery remotely would be at high risk of COVID-19. So surgery can create a state where the immune system is not as strong to fight off infection, but that's only in the first few weeks after surgery, so about 14 days following surgery where that is the case. So if your surgery is further away than that, then you are not at increased risk of getting COVID-19.
Okay, so you mentioned patients, longnet patients, in certain scenarios might be a little bit at a higher risk. So we've had a question from someone who wants to know how longnet patients and/or patients with reduced lung function can best protect themselves from the COVID-19 infection and symptoms to watch for in their case.
So first off, for the susceptibility of patients with long neuroendocrine, I should mention that it would be if your long neuroendocrine tumor reduces your lung capacity. So if you already have a compromise in lung function because of the tumor, for example, because there's a heavy tumor burden, there's a lot of tumors in the lungs, or if you have an other lung disease that adds to that, like emphysema, asthma, or bronchitis. So having the long neuroendocrine in itself is not necessarily a higher risk. It really depends on the extent of this and the impact it had on your lung function. In terms of ways to better protect yourself, there is nothing specific to long neuroendocrine tumors. I would say it's the same for all patients, and it's the same for the general population. So stay at home, wash your hands often, don't touch your face, and avoid physical contact. So if you have to go out, maintain 6 feet distance all around. And then something that I think is quite important is yourself to stay at home, but tell others to do that too. I think that especially with all the messaging in the media about vulnerable population needed to be protected by social distancing and physical distancing, cancer patients have a unique voice here in telling your loved ones, telling your friends, telling your neighbors to, stay at home. It's going to help me and it's going to help you. And so that's also important.
That's a really good point. So on that same theme about people who are at higher risk, we have a question from a viewer who wants to know if people who are insulin dependent and diabetic, if they have any specific risk.
And that's very important. There's been a lot of discussions about diabetes in particular around COVID-19. So the insulin dependence doesn't portend a higher risk in itself. Diabetes overall as a group of diseases is a comorbidity. So we know that patients that have comorbidity have a higher risk of getting COVID-19 because they're more vulnerable. So diabetes is one of those comorbidities, like is heart disease or lung disease, for example. So there's a slightly higher risk. And the best way to protect yourself is, like I just said, stay home, wash your hands, maintain a reasonable distance when in public.
Okay. And what about patients who are underweight? We have a question from as a result of major surgery, and they want to know if they're possibly at a higher risk.
So that's, I would say, similar to diabetes. Being underweight can be a risk factor to developing any type of infection, or if the nutrition status is different, and that's a reason why someone is underweight, it might be more difficult to fight off an infection if you get COVID-19. So it's possible there's a slight increased risk, although we don't know exactly how high that increased risk would be. And the best thing to do then is the same thing, is try to stay at home and maintain physical distancing and frequent hand washing.
Okay. So the next question that I'm going to present to you is about people who have undergone chemo or radiation. The question is, how long after chemo or radiation would we have a suppressed immune system, and how would that affect chances if we were exposed to COVID-19?
Yeah, that's a very relevant question, and frequent for anyone with cancer. So what happens with chemotherapy is chemotherapy can have side effects on your bone marrow, and because of that, the white blood cells are not produced as much. So what happens is some of the white blood cells that would be used to fight a virus infection, which are called lymphocytes, can be down. We call it lymphopenia. There's another type of white blood cells used to fight infection, although more often bacteria infection, called neutrophils, that if they're down, we call it neutropenia. Chemotherapy can result in those white blood cells being down, and it's usually about 2 weeks after you've finished your treatment of chemotherapy. That's why when you get chemotherapy, we use what we call cycles, meaning you have treatment and then you're sort of off treatment for 2 to 3 weeks, and then there's another one. That's to allow the body to recover between the treatments. So the moment where the immune system might be suppressed is about 2 weeks after chemotherapy. And how often will that happen will depend on the type of chemotherapy you're getting. So the best thing to do is probably talk with your oncologist and ask about your specific type of chemotherapy. And then your oncologist can also check your blood counts to know whether your white blood cells are low or not. Because what I'm trying to say is, it's not because you get chemotherapy your immune system is necessarily down. It might be down at a certain point in time, and then it will recover. So it's a dynamic process, and we can measure that looking at blood counts. Now we have to be careful as well to not measure blood counts like all the time, because doing that means you have to go to either a lab close to you, or you have to go to hospital to get your blood count. So we have to be careful about ordering it at the right time, at the right interval, and not too often, to avoid unnecessary exposure to social contact as well.
Okay. And with respect to radiation,
So radiation itself doesn't produce any suppression or compromise of the immune system. I don't know if the question had to do with PRRT or just the external radiation therapy, because those would be two different things. So external radiation will not have impact on the immune system. PRRT can have impact on the immune system. So similar to chemotherapy, PRRT can reduce the function of blood marrow. So you produce fewer white blood cells and you produce fewer lymphocytes that would fight the virus. The difference with chemotherapy is that this effect from PRRT can last for longer. We say that usually it's about 6 weeks after the last treatment of PRRT where you can have suppression of the bone marrow and thus have impaired immune system. Again, you don't have an impaired immune system for these entire 6 weeks. It's a dynamic process and depends on how your bone marrow is reacting. And so that can be measured by a blood count looking at the specific white blood cells.
Okay, so I'm going to turn now to some of the questions that have come in from people who are watching. This question is, could octreotide have a role in dampening the cytokine storm that some people with severe COVID-19 experience?
That's a very interesting question. From what I know about octreotide or somatostatin analogs, not that we know of, I don't think that there's data available on that. Octreotide in itself usually is not involved in any immune reaction. It's really an anti-hormonal, anti-tumoral therapy specific to neuroendocrine tumors. So not that I know of that it would impact inflammatory or irritation reaction triggered by the virus. However, what is nice about octreotide or somatostatin analogs in general with neuroendocrine tumor is it provides a way to keep the tumor under control and to keep it quiet and sort of asleep, I like to say, with only a treatment which is an injection monthly. So it's a way to keep tumor control with very minimal exposure to the healthcare system or the cancer center while we're going through this crisis. So it's a nice tool to have for this type of disease, especially in those times.
Okay. So the next question is, would DIPNEC be considered a comorbidity? So perhaps before you answer that, you could explain to the viewers, not everyone may know what DIPNEC is.
Yeah, so DIPNEC is this sort of disseminated form of neuroendocrine tumor within the lungs in particular. And it's sort of a different entity than lung neuroendocrine tumors themselves. In general, I'd say that it's the same as for the lung neuroendocrine tumors. It depends on the impact on the lung function. So if the lung function remains normal and the volume of the lesion is low, then there shouldn't be any impact. It doesn't necessarily increase the risk of getting COVID-19 if the lung function is normal. It doesn't compromise the ability to fight the infection if you get it.
Okay, great. So I'm just going to change gears a little bit and ask you some other questions about that we received in advance with respect to accessing care during this time. So what are your recommendations for patients with respect to oncology appointments? Many of us are still visiting the hospitals for CTs, MRIs, and lab work, but we want to know if follow-up appointments can and should be done via Zoom or other virtual means, and should we even be attending MRIs or should we cancel them?
Yeah, that's a really big question right now. So I think I'm going to answer this in two parts. The first part is about imaging and sort of testing, and the second part is with regards to the appointments with doctors via Zoom or the telehealth tools. So first off, for all the testing, I would say that is very, very individual dependent. So, a lot of the answers I'm going to give today are that the decisions have to be made on a case-by-case basis. Neuroendocrine tumors are very different. Every patient is different, and the needs of every patient is different. So it depends why the imaging or the tests are being done. In general, I'd say talk with your oncologist and inquire about, the indication for the test and what would be the impact of delaying this to after the pandemic. A lot of centers have proactively looked into delaying what we call the well follow-ups. Well follow-ups are patients who are being, are stable in their disease and are being monitored. And if we monitor now, we monitor in 3 months, it won't make much of a difference, but it can protect someone from having to come into the cancer center or the hospital. So a lot of centers are doing this proactively. If they're not, and I would encourage everyone to advocate for yourself and ask those questions and ask whether you can safely delay your tests. For example, anyone that has tests, so for monitoring, let's say you have tumors, you're treated with long-acting somatostatin analogs, and this is a checkup to make sure the tumor is still stable. If you're feeling well and have no symptoms, it can be totally safe to delay things until this has passed. So another scenario is patients who had surgery, they currently have no evidence of tumor, but they're being surveyed to make sure the tumor doesn't come back. Those are tests that can potentially be delayed safely. And then finally, another category which would be different is if you're experiencing symptoms and there's thought that the tumor might be changing or progressing, then maybe the imaging is necessary and will lead in changes in outcomes or changes in treatment. So I would say talk with your physician, ask what's the indication for the test, and whether doing the test now will alter your management or will alter your outcomes. And if the answer to that is no, it does not alter management, doesn't alter outcomes right now, and can probably be safely delayed. The second piece is about appointments with physicians, and whether we can use sort of telehealth tools for that. So there's been a huge shift in telehealth with COVID-19. I think that's probably one of the good things that will come out of this pandemic is a lot of places were sort of slow in taking that shift towards telehealth, and this will probably force things and potentially for the better going forward, because we have to be very creative and develop new ways of connecting with people. So ask your doctors. Often in the past, at least in Canada, there's a limitation to telehealth because of legislation and sort of administrative issues with the healthcare provision. But right now, those have mostly been lifted across Canada, meaning that most healthcare jurisdictions are now allowing that we do appointments via any virtual mean possible, including phones, Zoom, FaceTime. In Ontario, we have an Ontario telemedicine network we can use, although it's not able to cover all physicians at this point. So there's a variety of tools that can be used. Ask your providers for that. The few things you have to know is that depending on what tool it is, it might not be a secure line and there might be a slight risk for personal health information. So you'll be informed of that at the beginning of the appointment, and you'll have to provide consent to have the appointment in that manner. And then the thing that might be difficult is it's a nice way to communicate with people. At this point, it's probably safer to avoid coming in and avoid the social contacts come into hospital for clinic visit involved. But there is something that some sort of personal communication and personal touch you're losing by not being in person, and that sometimes can be quite awkward, so you might have to get used to it. But in general, so far, I've been on my clinics on the phone, and most patients have been very thankful. And I've actually found that I've had sort of even longer appointments and more in-depth discussions somehow. Patients seem to be sometimes more comfortable asking questions they were not asking before. And I thought that was a very nice sort of side effects of all of this. So try it and you might like it. And I'm starting to think that we might not want to go back sometimes.
Wow, that's very interesting. Although I do agree with you that you do lose something when you lose the face-to-face aspect, but that's very interesting. So if patients do decide to go to the hospitals for scans, or even if it's warranted for them to go in for appointments, should they be wearing masks in the hospitals and gloves?
Yeah, that's a very good question. I think even the CDC in the US hasn't come up with a consensus answer on that. So a few things to take into consideration. So maybe I'll just give a little bit information about like COVID-19 and how it's contagious. So COVID-19 is located mostly in your throat and your upper respiratory tract. That's the throat, the mouth, and etc. And the way it can be communicated to someone else is through droplets. So I'm going to be quite graphic here. If someone sneezes on you or spits on you or things like that, and sometimes you don't even see it, that's how you can get it. The virus is alive in those droplets, and that's how it's transmitted. So either from person to person, if you're very close to someone, that's why we say 6 feet is probably as fast as like spit will go. So that's why we say that's the minimum distance we should maintain between individuals. Or the other thing is if the virus from one of the droplets goes onto, let's say, a table or a doorknob, and then someone else picks it up and then puts their hands in their face, it can be transferred that way. So that's why we say, keep 6 feet distance, don't touch your face, and then wash your hands a lot as well. So to go back to the mask issue, the reason to wear a mask is not so much to protect yourself, but to protect others. So if you're having symptoms and you might have COVID-19, wearing a mask can protect others. If you don't have it, we don't know that wearing a mask protects you in general. I'm talking about the general population. It's different if we talk about healthcare workers. So if you go to hospital, wearing a mask won't necessarily protect you. If you go to hospital, you're gonna, in all hospitals now, there's a screening process. So patients can only enter through certain doors, and you will be asked whether you have symptoms. If you have symptoms and your appointment is not absolutely necessary, you will be asked to either go to a COVID screening center or to self-isolate. If you have symptoms and your appointment is absolutely necessary, and a phone call might be placed to your doctor to make that assessment, then you will be provided with a mask and you will be sent to a special area in the hospital for assessment and testing if necessary, and then to have your appointment. So if you need it to protect others and you need to be in hospital, then the protective equipment will be provided in most institutions. Now, I just want to mention something, because people might say, well, you know, we're talking about all those masks, and the PPE is what you hear means personal protective equipment, and how we need more. Why shouldn't I wear a mask all the time? So the mask that we talk about and that level of protection is really for healthcare providers, because when we care for people, we cannot be 6 feet away, right? Like, we have to be close to people. So that puts the healthcare providers at higher risk, especially when you go from patient to patient, especially because we care for people who usually have symptoms and are sick. So that's why all the surgical masks and the respirator masks are used for the healthcare providers, but for patients in general and for the general population, at this point, it's not absolutely necessary. And if you want to protect others when you're going out, then what you can use is those sort of cloth masks, or there's a lot of YouTube videos that you can find about how to make your own masks, and those are good if you want to use them for going out in public. That's a long answer, but I felt there was a lot to unpack there.
No, it's actually a pretty charged question these days, and you know, the answer really depends on who you're talking to. So with respect to MRI CT machines, if we do go and have these tests, I'm not sure if you know the answer to this, but do you know if the machines are wiped down in between patients, and do they need to be wiped down in between patients? Meaning disinfected.
Yeah, so there's a lot of like very detailed protocols for like infection control within hospitals at all times, and they're enhanced and heightened right now because of the pandemic. So yes, there's protocol to wash the consultation rooms, the imaging machine, everything that's being used for patient care. And those are very, very strict, and they're used, like the frequency has increased right now in most institutions in response to the pandemic. And by saying that, I really want to give a shout out to all the people who work at environmental services in our hospitals right now. I think we don't talk about them a lot, but they're really heroes in every day. In what we're doing. They don't care face-to-face for patients, but they're exposed to risk by cleaning everything, but they really like keep us safe by cleaning so much, especially right now. So if you see them when you go in hospital for a test, just say thank you, and I know they'll be very grateful.
That's really nice. So we have a very Toronto-specific question, our viewers from across the country, but this might apply to you know, different locations. So have the Toronto hospitals designated certain hospitals just for COVID cases, or are cases being treated at the cancer hospitals? Do you have any?
Yeah, so right now, as far as I'm aware, in Ontario, we do not have a system with COVID hospitals and non-COVID hospitals. So there's COVID patients that might be treated in all hospitals. Now, however, within hospitals, the COVID patients are in certain areas. So for example, and I know it's similar in other institutions, at Sunnybrook, we have a COVID ward where all the COVID patients are going, and there are certain sections of the intensive care unit where COVID patients will be. And the COVID screening center is a bit separate from the hospital itself. Like, it's still on the campus, but it's not in the usual care areas. So that's ways we're trying to sort of control things. Other provinces might have different ways. I know Quebec had this system of having COVID designated hospitals and non-COVID hospitals, and they have different phases. For instance, in Montreal, they initially had one COVID hospital in phase 1, and now in phase 2, they've opened 4, and then in phase 3, they're going to have more. This is what has, in other countries, they've done both. So in Italy, for example, they had this COVID and non-COVID hospital model, but eventually as the pandemic progresses, they realized it wasn't necessarily viable to do so, and eventually everyone becomes a COVID hospital. So at the end of the day, what is most important is to identify people with confirmed COVID that have a positive test, or what we call, you might hear this, people or person under investigation, which means it's someone who has symptoms but hasn't had the result of the test yet. So until proven otherwise, they're considered COVID. So the important thing is to identify those people and then isolate them and you protect them and protect others by having some dedicated areas in the hospital and knowing where those people are. So that's how we sort of try to control for that. But at the end of the day, because of the healthcare system is built and the amount of people that are going to have to be treated with COVID, I think a lot of provinces went with everybody's going to be treating those patients and will rather focus on isolating within institutions and having good infection control that way.
Okay, thank you. So I'm going to move now to a couple more questions that have come in from our viewers. I just want to mention to the viewers that I've received a few questions that are not specific to COVID, so I won't be asking those questions because this session is specifically about COVID-19. And Dr. Hallet, the next question is a little bit personal, so I'm not sure if you're going to be in a position to answer it, but I'll read it to you anyway. This individual is a primary adrenal insufficient who has a reoccurrence of NET lung tumor and uses a CPAP machine. If I were to contract COVID-19, can I be confident that ER doctors will recognize my steroid dependency? This is the greatest fear for all adrenal insufficient patients, whether they take steroids orally or by a cortisol pump, similar to the diabetes in an insulin pump.
Yeah, thank you so much for that question, because that brings up an important point. I think, you know, for adrenal insufficient patients, or it might also be true, you know, for someone with carcinoid syndrome, for another type of neuroendocrine tumor, and all those sort of unique conditions that impact your comorbidities, your health, and how you're to be managed. So one thing is right now, if you go to hospital for any reason, you're going to be asked all the questions about COVID-19, and COVID-19 will be on the differential diagnosis of almost any physician that's going to see you, just because of how things are and how common it is right now. And so when we are in a pandemic situation right now, when everyone is really overwhelmed and working so hard and seeing so many people, it sometimes can be easy to miss details. Not necessarily that we're not paying attention, and by we I mean all healthcare workers, but just because, you know, there's so much to do and so much to consider. So what I would say, and I think that's one of the great things that we have nowadays in medicine, is there's no better or more powerful tool than self-advocacy for patients. So, you know, I know in some jurisdiction or some people might wear bracelets that say you're adrenal insufficient or you have carcinoid syndrome to alert healthcare providers to that. So that's one way that people would know. But another way that people would know is just to say it. Just mention it. Tell the doctor, the nurse, the provider you're seeing, hey, by the way, I have adrenal insufficiency and I take those drugs to supplement my adrenal, and I have these health issues. I just want you to be aware, and is that impacting my diagnosis right now? Could that be related to what I'm experiencing? And is that impacting the treatment I should receive? And I think this is important at any time to be a self-advocate, but even more so now when everyone might be so overwhelmed by the virus. I don't know if that answers the question.
Thank you. So next question that's come in. This is also probably a topic that's a little bit sensitive. Worst case scenario, and we are in hospital with a serious case of COVID and don't want extraordinary measures taken. How do we know when we are not likely to make it so that we can advise doctors?
Yeah,
I know it's a
that's
tough.
a tough one. I think it's true for any major health issues that you might encounter. Um, it's really hard to predict how people are going to do, whether it's when you get a cancer diagnosis or if you get COVID and you get a pneumonia and you have to be in hospital. We don't have crystal balls in healthcare. I always say that if we had, I would make my job much easier. But I haven't met the person who could invent that yet. I'd say ask questions. So that's number one, ask questions to your healthcare providers and ask them point blank, like, what do you think are my chances of getting out of hospital? What do you think are my chances of needing to be on a ventilator, to be supported? And how am I doing? How is it going? Is it getting better? Is it getting the same? Am I getting worse? And just, ask the tough questions. And maybe the answer you're going to get is, we don't know yet. We have to take it day by day, or we have to take it hour by hour. That's really possible, but ask them. The second thing I would say is also, and those are difficult times, and those might be uncomfortable conversations, but take the time to think for yourself, what is extraordinary measures for you? So extraordinary measures for me or for my mom are two very, very different things. I had that discussion with her recently, and we don't want the same thing. So think about what that means for you. You can ask your healthcare providers to help you know what measures are available, so that you know what you would want and not want, and have those discussions with your loved one, with your families, with your caregivers and care partners, and make them aware and make your team aware. It's even better if it can be like, in writing. But even if it's not in writing, if you have the discussion, it's going to make it much easier for your healthcare providers. You have to tell them that you had a discussion and those are your needs. And you can say it early on, even if you're doing well and there is no acute problem, just say it. Like, I can guarantee that the doctors, the nurses, all the providers are going to be very grateful for you to do that and to tell them ahead of time. It's better, when things are going well, than when the situation it's much more difficult and then you're pressed by time. It might also take off a burden of the shoulders of your loved one that will not have to make those decisions for you. So it's hard to know when, because it's hard to know what are extraordinary measures for each individual. But the most important thing is just to have the discussion and ask to have it, and ask the tough questions and think about these things before you're confronted with the decision. Sorry, I hope that answers the question. I know there's no like direct or black or white answer here.
I think that was a very meaningful response. Thank you. I'm sure the viewers appreciate that. So the next, I'm going to do one more very patient-specific question, and then we'll move on to a few others that are a little bit more generalized. I'm a lung primary patient, had an upper right lobectomy with mets to other organs, and currently going through PRRT. I'm prone to respiratory infection. Is there anything different that I or patients in general can do to build our immune system and help us should we get the virus in the future? I think the question about people, how can they build their immune system, is a pretty common one. So what are your thoughts on that?
Yeah, that comes up quite often indeed. There's no sort of miracle solution or drug or genius tricks for this. So what I'm going to say might sound a bit generic, but it is truly meaningful. So keep a healthy lifestyle. So maintain a good diet, good nutrition, try to exercise so that your body and your mind is as strong as possible if you get the virus and you have to fight it. There's no other secret than that. So a healthy mind in a healthy body, and by that I mean especially in those socially distant times, It's important to be socially distant, but not completely apart. So, I'm saying good diet, try to take time to exercise, but try to also take time for yourself, and time to keep in touch with others, whether it's by virtual means or over the phone, etc. But that all these things are important to make sure that you're psychologically and physically as strong as you can be. And then if there's diet supplement that you can take if you have trouble maintaining a normal diet because of the tumor, for example. So, using Boost, Ensure, multivitamins and things like that can also help. And if you need to, you can ask your centers or your healthcare provider to talk with a dietitian to get even more information and advice in that regard.
Great, thank you. So I'm going to move on to a question about testing. Are cancer patients more likely to be able to get tested for COVID-19, or they just fall into the no test category if asymptomatic?
Yeah, that's a very, very good question. So right now, at least in Ontario, and I think most Canadian provinces are going with that, we're testing essentially people with symptoms. So for cancer patients, it's going to be the same criteria. So if you have symptoms, then you go to a testing facility and you can get tested, or you can contact your healthcare provider, or if you're in hospital coming for another visit, you might be directed to a testing area for patients who have to come in for appointments for other reasons. Now, because cancer patients are already and neuroendocrine patients are already in the cancer system, and have more frequent contact, even if those contacts are virtual now, with providers, and you might be screened more often for symptoms, and that might identify symptoms earlier and more often than for the general population. And in that way, the neuroendocrine patients may end up being tested more often than the general population. But without symptoms, right now, there's no testing. What I should mention, though, is, symptoms that we hear about a lot are fever, cough, or, a runny nose or sore throat. So like a bad cold, or, symptoms of the flu. But other things you have to look for would be body aches. There's also some times where this presented with people have trouble smelling. So that has presented in some instances. And it can also present with gastrointestinal symptoms like diarrhea or abdominal pains or things like that. So be aware. And if you experience new symptoms, you can either go to a testing center or contact your family doctor or your oncology provider and ask, listen, is this at risk? Should I get tested? And I would say personally, don't quote me to public health, but that it's better to have a low threshold in terms of symptoms, because we know those symptoms can be very mild, especially at the beginning.
Mm-hmm. So the next question is about once this pandemic is all over. Let's all hope that that's sooner rather than later. So once the population is given the all clear and we can circulate it openly again, should neuroendocrine patients stay isolated for a little bit longer than the general population?
Yeah, that's a very good question. I've been wondering myself how it's going to look like, when we open our doors again, and how exactly authorities are going to enact that. Are we going to be able to say, okay, tomorrow it's back to business, so normal business as usual, or if it's going to be gradual over time, that we're going to have more social contact again. And how long should we stay isolated safely? Because the big worry, and you might hear news from China about this, is what they call the second wave, right? So once you've sort of flattened the curve, if you reopen the doors and reopen social contact for everybody, there's a risk that there might be another bump in the virus and in infections. So like I suspect that there's going to be very gradual social contact when it is reinstated. Whether neuroendocrine patients should stay isolated for longer, I don't think so, because the risk of neuroendocrine patients overall is not higher than the general population. If you're someone who's in in a phase and in a moment in your treatment where your immune system might be compromised. Let's say you're 2 weeks from chemotherapy, for example, or you know your blood counts are low and might be more prudent and cautious to stay home a bit longer. But as a general measure, probably not.
Okay. And so on that same vein, we have a question from someone who has to travel for PRRT treatment. And so would you say the same about patients traveling after the pandemic is over?
Yeah, I think it's probably fairly similar. If travels are authorized and social contacts are deemed safe again, they would be for neuroendocrine patients, just like the general population. With regards to traveling for treatments, I think that this also warrants a discussion with your doctors and your healthcare team to know, what's like, number one, is the treatment still being delivered at this point in time? Number two, what are the potential drawbacks of delaying the treatment or not? And then that way you can potentially better weigh the risks and the benefits of leaving your home and traveling for the treatment. Now, with neuroendocrine tumors, there's a lot of treatments that we can potentially delay or have longer intervals between rounds of treatments without significantly impacting the outcome at the end of the day. Because it's a different type of tumor and the biology is slower for the majority of them. So I think a good discussions with your healthcare team is important there to decide when it's going to be the best timing for you.
Okay, so I'm going to ask another question related to PRRT. So this is not after the pandemic, but right now. Is access to PRT going to be affected by COVID-19, and specifically for someone who has not started treatment yet?
Yeah, that's a $1 million question. I would say first off, that will depend on the jurisdiction, so the province in Canada. The PRRT right now, as you know, is not available in the same way to all patients across the country. So that's the first thing. The second thing is the management of health resources and how many cuts there have been in the resources during the pandemic is very dependent on provinces and even regions and institutions. So right now, I know for Ontario, we have very limited access to PRRT at the best of times. Right now, patients who are currently on treatment will carry on with their treatments, but new treatments will be initiated only for patients that are heavily symptomatic so that we can provide symptom control, and then others might be delayed for later. But again, this is a individual decision based on the local circumstances and the delivery of PRRT, in regular times, based on local resources during the pandemic, and then based on individual circumstances for individual patients. So potentially contact your healthcare provider and check with them. I know I'm saying that a lot, and I feel bad because I'd like to provide better answers. But at the end of the day, there's so much variability in terms of tumor, in terms of patient experience, and in terms of availability of healthcare resources right now, that we have to individualize things a lot.
Mm-hmm. We understand. Thank you very much. So here's a question that I think you will appreciate very much, given your research focus. How is COVID-19 going to impact funding for cancer treatments, trials in the future?
Yeah, I've been reading and inquiring a lot about this. Thanks for pointing it out, Jackie. You were right on. So there's different things. First up, in terms of funding, the funding for drugs, at least I can say in Ontario, hasn't been altered by COVID-19. It hasn't been reduced, that's for sure. If anything, I would say in other disease sites, it actually has been broadened. So I don't think that there is any area for that in neuroendocrine that I can think of. But for example, in pancreas cancer right now, we're looking at funding chemotherapy prior to surgery, which was not funded before, so that we're able to use those treatments in patients that may not have access to surgery at the moment. So that's an example of Ontario, but I think in general across Canada, most cancer care systems are very, very aware of the fact that we have to adapt our practices, and they're willing to have the flexibility during the pandemic to do so and to facilitate care for patients and for providers. So if anything, I feel like the funding is going to be opened up a bit or loosened up, at least temporarily, to help provide good care for patients and not be a barrier to adaptation and care we have to make during the pandemic. With regards to clinical trials, this is again dependent on the trial and what the requirements of the trials are. I would say that in general, the instructions we'd received from research institutes is that we are not initiating new trials. So trials that we're about to open, the opening might be delayed. For patients that are currently on trial and are currently receiving drugs, in general, the trial will continue. There might be some adaptation in terms of the schedule for follow-up or the test that you're undergoing as part of the trial, as to minimize social contacts, as we've talked about before. And then in terms of enrollment, like new enrollment into a currently open trial, that is on an individual basis depending on the trial. So again, will depend on the institution and the jurisdiction.
Okay, thank you. One more question. I think if we can squeeze one in, I'm going to bounce around again, and I apologize for bouncing back and forth on topics, but this is again about testing. Can a neuroendocrine patient get tested to know if they are immune to COVID-19?
That's very interesting. I'm going to be honest, I hadn't thought of that one yet. So I'm going to answer on the fly, but we don't really know whether there's a lot of immunity for COVID-19 out there already. The whole reason why this pandemic is such a big problem right now is because we don't have immunity for it, because it's a new version of the virus. So coronavirus is a virus that exists, right? It's in a lot of kindergarten, in a lot of daycare. You know, kids have it all the time, but different versions of the virus. The version we're dealing with now, which is a SARS, SARS coronavirus 2 is the exact name for it, that creates the disease COVID-19, is a new form of the virus. And it's a form of the virus that humans have never faced before. And because of that, we do not have immunity. That's why the virus can infect so many people in such a short amount of time, because we don't know how to fight it. So there's no built-in immunity in humans for it right now. So I don't know that we'd be able to identify immunity in lots of people, because very few people would have it. We don't even know right now whether once you had COVID-19 and you recovered for it, if people are immune to it, like if they can be reinfected or not. This is still the subject of a lot of research, and the Chinese are sort of in a time right now after the outbreak where they can study it. So I guess the answer is I don't know, because we don't even know whether we can develop immunity after being infected with COVID-19. There's tests that are being talked about detecting like antibodies in the blood. I know there's a lot of discussion about it in the US right now to see whether people are immune, but we don't know how many people are immune and whether those antibodies would confer a real protection against an infection or not. So the answer is, I don't know that testing exists now, that it's available, that it would impact how we behave or the care we provide.
Great, thank you. Once again, very informative response, and thank you for taking the time to respond to all these questions. It was, I think, very informative for sure. So before we wrap up, is there anything that we haven't touched on that you think you want to share with the neuroendocrine community about COVID-19?
I guess there's sort of three things that, sorry. The first one is when we talked about wearing masks for patients or, for the general population, if you do choose to wear a mask, just be cognizant that it's not an armor. It doesn't protect you completely for the virus, and it doesn't obviate the need to do all the other things you should be doing. So if you have a mask and you touch your mask with your hands, and then you take the mask off and you touch your face again, then you contaminated yourself. So a mask still means that you still have to wash your hands, still have to stay 6 feet away from everybody else, from a different household, that is, and you still have to avoid touching your face. So it can be good, but it doesn't obviate the need to do everything else. It still means stay at home, wash your hands, stay 6 feet away from people, don't touch your face, those are the most important thing. I know that we've been repeating it and hammering the message, but it is because that's really what works, and that's really what's the most important thing right now. The second thing is this generates a lot of anxiety for everybody. For patients, that's why I'm so happy to be able to do this session today for the public, but I would say also for the healthcare workers and for all the people who work in the healthcare system. So I just want to send a message that we are all very dedicated to caring for everybody and provide the best care experience, but we're really dealing with a lot right now and having to do a lot of changes quickly. So if things don't work as smoothly as you would hope so, I do apologize, but I would ask your understanding and be kind to all the administrative people you talk to and the people you meet in hospital, because they're just part of the public as you are, and they're just as stressed as you are. And being kind to each other will really help us get through this. So that was my last message.
Wonderful. Thank you so much for your time today. We appreciate it so very much. It's been an incredible session. So thank you for taking time out of what I'm sure is an incredibly crazy schedule.
Thank you.
Wonderful. So for all of our viewers, this webinar will be available on our website if you missed the beginning or any aspect of it and you'd like to watch it again, or you want to share it with any fellow patients. So thank you all for joining us, and thank you again, Dr. Hallet.
Thanks. Goodbye, everybody.
Goodbye.